Okay, so hello bachcho, good evening, namaskar all of you. I'm Dr. Dinesh and we are live for this class, second year MBBS live pharmacology class for cardiovascular system. The topic for this month will be CVS cardiovascular system. Important topic, we are going to discuss around 25 MCQs in which we are going to revise some important topics. So, सबसे पहले हैप्पी होली एवरीवन. वी हैव होली फेस्टिवल, सो होली मुबारक सबको. तो सबसे पहले बात करते हैं गाइज. क्वेश्चन नंबर 1. A 52-year-old diabetic hypertensive patient diabetic है, patient hypertensive भी है, developed dry cough after starting medication. What is most likely drug? A very simple question, but in second year this is one of the very important topic. So you can see the age of the patient. The age of the patient is 52-year-old. You can see the patient is diabetic. The patient is hypertensive. The patient is having dry cough after starting the medication. So when we talk about antihypertensive drug, mainly we use these drugs. If the age of the patient is less than 55-year-old, then the first line drug we start is the ARBs, angiotensin receptor blocker, or ACE enzyme inhibitor. And if the age of the patient is 55-year-old and old, then we start the drugs like calcium channel blockers and drugs like diuretics, thiazides. These are the drugs which are first line. Beta blockers are nowadays not the first line drug. So beta blocker is not a first line drug. Definitely we are not going to start. And even in diabetic patient, beta blockers are not safe drug. The patient is diabetes, so we have to always consider what is the benefit of the drug in diabetic patients. In diabetes, either you need to control the diabetes or you need to give the drugs which can help the diabetic patient in any other way. So out of these drugs, if you see losartan is one of the angiotensin receptor blocker, RAS pathway inhibitor. Enalapril is the ACE enzyme inhibitor. Amlodipine is a calcium channel blocker, and metoprolol, it's a beta blocker. Out of these, beta blocker should never be used in the diabetic patients because they can cause problem with the diabetes in diabetic patient. They have if the patient is on beta blocker, there will be more risk of hypoglycemia again and again, because beta block, that means you block the gluconeogenesis. So that because of this, there will be repeated hypoglycemia, and beta blockers also mask the warning sign of hypoglycemia. So beta blockers are not the good drug. Amlodipine is a calcium channel blocker, safe in diabetic patient, but there is no benefit. But losartan and enalapril, these are RAS pathway inhibitors, and these are having benefit in diabetic patient. So these drugs decrease the microvascular complications in diabetic patient. Microvascular complications in diabetic patients will be decreased, especially the nephropathies, especially the risk of nephropathies. So basically these drugs are causing dilation of efferent arterioles. By dilating these efferent arterioles in the glomerulus, they will help to decrease the risk of nephropathies. So that's why in diabetic patient, in hypertension, these are the first line drug. So we have to start out of these. But in this patient, after starting, the cough was there, dry cough. So if you give ACE enzyme inhibitor, they inhibit the ACE enzyme. So what happens? Because of this, even the bradykinin metabolism will be inhibited. Because ACE is one of the enzyme. If you inhibit the ACE enzyme, bradykinin level will be high, because bradykinin will not be metabolized. And because of increased bradykinin, there will be the common side effects like dry cough. A typical Brazzy cough, the characteristic name of this cough is Brazzy cough. Dry cough, angioedema, rash, and urticaria. So these are the important things. Easy to remember, DARU, D-A-R-U. So dry cough, angioedema, rash, urticaria, all these. Yes, bache, very good. So you can see this is enalapril. We started in this patient having cough. What is the best solution? If the patient after starting these drugs having the cough, what you will suggest? Kya karna chahiye? The patient is on ACE enzyme inhibitor, having the cough, angioedema, always switch the patient from the ACE enzyme inhibitor to ARBs. So you can switch this patient from ACE inhibitor to ARB, then you will find there is no issue. So there are around 10% patients who are having the cough after few weeks of these drugs. So that is the important adverse effect of this drug. That is a type B type of adverse effect, which is unpredictable. So you cannot predict. Very important. So always be ready to switch. Nowadays, if you see, we prefer the ARBs, we don't prefer the ACE enzyme inhibitor. The next question: a patient with variant angina. A patient with variant angina should receive which drug? So what do you think? Which drug should be given to the patient of variant angina? Propranolol, nitroglycerin, aspirin, or digoxin? So these are the four important. Propranolol is a beta blocker, LOL. Nitroglycerin is a nitrate group of drug. Aspirin is the antiplatelet drug, and digoxin is the drug which is inhibiting the sodium potassium ATPase. So if you see variant angina is a type of angina where you will see the vasospasm. It is also called as Prinzmetal, and it is due to vasospasm. So in these patients we need vasodilator. What is the treatment? The treatment is vasodilator. We give the vasodilator in these patients so that you can relax this spasm. It is commonly seen in the female. It is commonly seen in the cold winters. It is commonly seen in early morning, chilly winters, early morning, female having sudden vasospasm, typical chest pain, ischemic type of pain, not ischemic type, it is ischemic pain. So if the patient is having variant angina, digoxin is having no role in angina. Digoxin is a drug which is positive inotrope. So that is the drug for heart failure. It is not for angina. Aspirin and propranolol are not safe. These are not safe in these patients. Never use these drugs. Aspirin is usually we use in ischemic heart disease patient, but never use aspirin if the patient is having Prinzmetal angina. You know why? If you give the aspirin decrease prostaglandin. Aspirin will decrease the prostaglandin. Aspirin will decrease prostaglandin. If the prostaglandins are decreased, vasodilation will decrease. So there will be risk of vasoconstriction. So never use aspirin if you are suspecting Prinzmetal angina. You can use aspirin in other angina or MI, but not in these patients. Beta blockers, everybody knows beta blockers are causing vasoconstriction. Propranolol is a non-selective beta blocker. Do not use in peripheral vascular disease. Do not use in Prinzmetal angina. Do not use in asthma. So that is not safe. So out of these, the safe drug is nitroglycerin, which is a vasodilator. Even though it is primarily venodilator, but still it is relaxing the coronary vessels as well. So in the Prinzmetal angina, you know what is the best treatment? The best treatment is initially in acute condition you give the nitrates, and then we start the calcium channel blockers. So overall these calcium channel blockers are the regular drugs in these patients. They are the drug of choice in Prinzmetal angina. So always remember CCBs are the primary. So if they ask you what is the drug of choice for Prinzmetal angina, always say it is the calcium channel blocker. But in acute condition, we start with the nitrates. So GTN is used. So nitroglycerin can be given, not the calcium channel blocker. I hope you understood. This is a very important concept. Aspirin पे गलती करते हैं, तो never use aspirin in these patients. Let's see the next question. A 60-year-old male anterior wall MI develops hypotension and cardiogenic shock. Very common. BP is 70/40. Which drug is preferred? So if you see 60-year-old male anterior wall MI develops hypotension, it's a typical case of acute pump failure. It's a typical case of acute pump failure. The heart is not working. Why? Because of the sudden MI. So if there is MI, myocardial infarction, due to myocardial infarction, The patient is having acute pump failure. The most common cause of acute pump failure is MI. Infarct. Heart wall is not pumping. Infarct is there. So if heart is not pumping the blood, the BP will fall and that leads to shock, cardiogenic shock. Which drug you will prefer? Dopamine, dobutamine, nitroglycerin or propranolol. Out of these, which drug you will start? If I ask you, if the patient is having acute pump failure, which drug you will start? So in these patient, acute pump failure, cardiogenic shock, which drug you will start first? Always and always, we give the positive inotrope. We give the positive inotrope plus we give the vasopressor. Plus we give the vasopressor. That is the complete treatment. Give the positive inotrope drug, give the vasopressor drug. So which is the first drug we add in these patients? The first drug in these patients we add is the dobutamine. That is the best inotrope for these patients. And the important drug we use is the NORCET. Important drug we use is the NORCET. So these drugs we give in these patients. Never give adrenaline, never give dopamine as a choice in these patients because they have the risk of arrhythmias. They have the risk of arrhythmia. Now see, propranolol. There is no use, even it is risk. Beta blockers will suppress the heart. Already heart is not pumping. Never use beta blocker. Nitroglycerin. Nitroglycerin is for ischemia. Nitroglycerin will decrease the preload. There is no role in pumping. Already pump failure, nitroglycerin will cause venodilation, less blood coming in the heart, less end-diastolic volume, even there will be decreased cardiac output. So never start with the nitrates if the already pump failure. So out of these, dopamine is not used because there is risk of arrhythmia. Dopamine is having role in these patients but not preferred because of risk of arrhythmia. So the drug we prefer in these patients will be dobutamine plus NORCET. Dobutamine cannot reverse the shock. But dobutamine is the drug which increase the pumping. So first increase the pumping, positive inotrope, and then give the vasopressor NORCET. So NORCET is the best vasopressor in these patients to increase the blood pressure. So don't be confused by the dopamine. I hope I have given you very important concept. First dobutamine, but first start the pumping. First start the pumping and then control the or increase the blood pressure, vasopressor. If you directly give vasopressor, BP will increase. Heart is already on load. So what happens? There will be risk of arrhythmia. So first start the inotrope. First drug. It is written in the guidelines. First start the inotropes, positive inotrope drugs. Okay. So let's see the next. A patient with atrial fibrillation and heart failure need rate control. What is the preferred drug? Verapamil, digoxin, nifedipine or lidocaine. Patient of atrial fibrillation, again atrial fibrillation can lead to heart failure. If the patient is having atrial fibrillation, it means rate is very high. Heart failure is there. So we need to control the rate. And what is the preferred drug in these patients? Very interesting question. Verapamil, digoxin, nifedipine, lidocaine. What do you think? What you will use? Patient of heart failure means pumping. We need a drug which is positive inotrope. We need a drug which is controlling the rate, means negative chronotrope. We need to select a drug like this which is having both these actions. Positive inotrope means increase pumping. Negative chronotrope means rate control. So if you see the choice, verapamil is a calcium channel blocker. Then we have the digoxin. Then we have the nifedipine, that is also calcium channel blocker. And lidocaine is a sodium channel blocker. So if you see these drugs, verapamil will definitely control the rate. But verapamil is negative inotrope also. So it can decrease the pumping. Never use calcium channel blocker if there is heart failure, if there is pump failure. Never use. So in heart failure, negative inotrope drugs like calcium channel blocker not used. The only negative inotrope which can be given in heart failure is beta blocker. That is only for grade 1, grade 2 heart failure. Not in grade 3, grade 4, not in severe heart failure. So beta blockers are having some role. They can be given safely in some patients, not for all the patients, but calcium channel blockers are not safe. Now, lidocaine is not a drug for this patient because lidocaine is good for ventricular arrhythmia, not for atrial arrhythmia. So we have a wonderful drug, and that is digoxin. Digoxin is a drug. Digoxin is a drug which is having both these property, as I told you. Digoxin having both these property. Digoxin is a positive inotrope drug. Digoxin is negative chronotropic drug, because digoxin is having this effect because of sodium potassium ATPase inhibition. It's a sodium potassium ATPase inhibition. Sodium potassium ATPase inhibition. And digoxin is negative chronotrope because of vagomimetic. Vagomimetic. Increase acetylcholine. So this acetylcholine, vagomimetic effect. This acetylcholine will slow the conductions. It increase the refractory period of conduction pathway. Mainly it control the conductions at AV node. Maximum effect is there, AV node. So it's a wonderful drug. So digoxin is the drug for this case. Otherwise digoxin is not a good drug. Lot of arrhythmias, lot of risk. So digoxin is the drug which can be used for these type of patients. Next question again on the ACE enzyme inhibitor. The question is ki ACE enzyme inhibitors are contraindicated in which condition? So guys, there are two important contraindication. There are two important contraindication of ACE enzyme inhibitor. Two contraindications are there. 1 and 2. Only two. One is pregnancy and second is bilateral renal artery stenosis. In pregnancy, there is a risk of renal agenesis. In pregnancy, there is a risk of renal agenesis. In bilateral renal artery stenosis, there is a risk of acute renal failure, because if there is stenosis, already oliguria, if you give this drug, they will dilate the efferent blood vessels. I told you, they dilate the efferent blood vessels, GFR drastically decrease, and that leads to anuria. So that's why risk of acute renal failure. So in this case, you can see in post-MI, we use, it is the drug which decrease the remodeling risk. In heart failure, they are used. They are decreasing the risk of remodeling in heart failure, in post-myocardial infarction. In diabetes, they decrease the risk of nephropathies, but never use in these patients. Bilateral renal artery stenosis and pregnancy, only two contraindications of ACE enzyme inhibitor and ARBs. Otherwise, there is no absolute contraindication. They are the wonderful drug. In black race, they are not effective. Negro, black, African people, they are not effective. Otherwise, that is a genetic, genomic. Otherwise, they are the superb. Nowadays, they are one of the commonly used, and they are the first line antihypertensive drug. Next question. Drug useful for digitalis toxicity with arrhythmias. So patient is having digoxin toxicity with arrhythmia. In digoxin toxicity, arrhythmia is commonly seen. And you know which type of arrhythmias are more common? Which arrhythmias are more common? The most common arrhythmia in digitalis is ventricular arrhythmia, because there will be ventricular extrasystole, and due to ventricular extrasystole, ventricular arrhythmias are there. So there will be ventricular extrasystole, ventricular premature beats, ventricular tachycardia, ventricular fibrillation. So these are extra beats in the ventricles because there will be extrasystoles. There will be extrasystole. So because of extrasystoles in the myocardium, ectopics in the myocardium, there will be arrhythmias. So how to control these arrhythmia? I told you, if there is ventricular arrhythmia, we need to block the sodium channel blockers. And in sodium channel blocker, we use the specific class 1B drug. And in class 1B drug, we have phenytoin, we have lidocaine. These drugs, lidocaine is the drug of choice in these cases. So give the lidocaine injection, that is the drug of choice. That is the drug of choice. So lidocaine is the drug of choice in these cases. Verapamil is for calcium channel blocker, that is to slow the conductions. It is not having any role in ventricular arrhythmia. Amiodarone is a good drug, but not best in these patients. And propranolol is again beta blocker, not a drug for this patient. So amiodarone and lidocaine both are for ventricular arrhythmia. In these cases, lidocaine is the drug of choice because lidocaine control the sodium channels in inactive state. Already inactive state, already closed sodium channel, it increase the duration of this closing. So in this digitalis toxicity, already the myocardium is leaky, and in these myocardium areas where the extrasystoles occurs, lidocaine is having role in only in these type of areas, and that's why it is a specific drug for this type of patient. So lidocaine is the drug which is increase the duration of inactivation of sodium channel. Already sodium channel inactivation, it increase the duration of this inactivation in these areas, and that is the drug of choice for these cases. Drug, next question, drug that reduce preload predominantly. So the drug which reduce the preload predominantly. So we have the vasodilators, and you know the vasodilators, we have the veno, we have artery, veno, we have artery, and we have the mixed vasodilators. So venodilators means decrease the preload, arteriodilатors will decrease the afterload, and mixed vasodilators will decrease the pre plus afterload. So pre plus afterload. So now you can see out of these which is mainly venodilators. In this we have nitrates, which is mainly arteriodilatator. We have calcium channel blockers, potassium channel opener, hydralazine. Rest of the all drugs are mixed vasodilators like sodium nitroprusside. Diuretics, ACE inhibitors, all these are mixed vasodilators, but primarily these are used as vasodilators. So nitrates are veno, nitroprusside is mixed, but calcium channel blockers, potassium channel opener, hydralazine, they are arteriolar. So hydralazine is arterial, nitroglycerin is definitely yes, minoxidil is a potassium channel opener, that is arterial. Alpha blockers are mixed. So prazosin is alpha blocker. So nitroglycerin is nitrate, and they act predominantly on the venous system. They release the nitric oxide, and this is predominantly acting on the venous circulation. Nitroglycerin, nitric oxide release, and this nitric oxide will increase the cyclic GMP pathway. So that's why they are used for angina, because nitroglycerin will decrease the preload. So decrease the preload will decrease the oxygen demand. Chaliye, let's see the next question. The first line drug they are asking in stable angina prophylaxis. Stable angina. In stable angina, what happens? In stable angina, there is atherosclerosis. There is atherosclerosis, narrowing. So because of narrow lumen, the lumen is narrow, blood circulation is less, there will be ischemia. Usually there is no pain because these resistant vessels, they are already relaxed because of hypoxia. These are already relaxed, so there will be no ischemia, there is no pain. But when the demand will increase, they cannot dilate further. When the demand will increase, they cannot dilate further, they are already fully dilated. And that's why this is called as exertional angina. This is called as exertional angina. So there will be typical history कि patient is having chest pain on exertion. That is stable angina. The plaque is stable. The plaque, atherosclerotic plaque is stable. And because of this, there will be decreased blood circulation. There is a plaque, stable plaque, decreased blood circulation, usually no pain, chest pain on exertion, relieved by the rest. So guys, what you will do? We need to give the prophylaxis. We need to give the prophylaxis so that the patient will not have the chest pain again and again. Now definitely, because there is already atherosclerosis, so the best thing you can do is you can revascularize. You can apply the stent if the blockage is more. If it is a severe blockage, definitely we go for angioplasty. But what about the drugs? The drugs, the best way in these patients is decrease the oxygen demand. If you decrease the oxygen demand, there will be no issue because dilation of blood vessel is not possible here. Already atherosclerosis, hardening is there, you cannot dilate it further. In resistant vessels, already they are dilated, you cannot dilate further. So what you can do, you can decrease the oxygen demand by decrease the workload of the heart. By decreasing the workload of the heart. So how to decrease the workload? To suppress the heart. So you can see, digoxin is the drug which is positive inotrope. It will increase the workload. Furosemide is not having direct effect on heart. Furosemide is a diuretic. It's a diuretic Definitely it can decrease some workload over the heart, but it is mainly for if there is already extra fluid, extra load, then only it will be effective. If there is edema, extra load, then only it will be effective. It cannot decrease the normal load. Dobutamine is increase the load because dobutamine will force the heart. It will increase the heart rate. The more oxygen demand will be there. If you want to decrease the oxygen demand, the best way is to suppress the heart is a beta blocker. The best way to suppress the heart is the beta blocker. So beta blocker propranolol is the wonderful drug. So in these cases we give the beta blockers. Beta blockers are the drug of choice. So I told you Prinzmetal angina, CCBs are drug of choice. Stable angina, beta blockers are drug of choice. In acute attack, nitrates are used, but otherwise for prophylaxis, for chronic, for regular use, in stable, beta blocker, in Prinzmetal, calcium channel blocker. So beta blockers will decrease the oxygen demand. So that's why they are the drug of choice in these cases. So give the beta blocker. Next question, class 1B antiarrhythmic drug. Important classification, Vaughan-Williams classification. So quinidine, remember quinidine, disopyramide and procainamide, QDP. These are class 1A. These are class 1A. Then phenytoin, lignocaine, tocainide. These are class 1B. Then encainide, flecainide, propafenone, moricizine. These are class 1C. So you can remember these drugs because these are important. So QDP 1A, PLT is 1B. So out of these important is quinidine, procainamide. Out of these important is lignocaine. Lignocaine is commonly used. And out of these important is encainide, flecainide. Encainide, flecainide. These are class 1 drug. And this, procainamide, but Q is quinidine. So, if you see quinidine, that is class 1A. If you see lidocaine, that is class 1B. If you see amiodarone, that is class 3. And if you see verapamil, that is class 4. So remember, class S, B, P, C, A, sab paka. S for sodium channel blocker, B for beta blocker, P for potassium channel blocker, C for calcium channel blocker. सब पका याद रखना है, सब पका, तो सब पका. These are the drugs for Vaughan-Williams classification for arrhythmia. So this amiodarone is potassium channel blocker, verapamil is calcium channel blocker, lidocaine is the drug which is used in ventricular arrhythmia. It is sodium channel blocker. So this is class 1B, sodium channel block with potassium channel open. This is sodium channel as well as potassium channel, both are blocked, class 1A. In class 1C, sodium channel block, and there is no effect on potassium channel. So that is subdivision. So remember, these are class 1 drug. So this is class 1B. Okay, let's see next question. Patient present with acute pulmonary edema, severe bradycardia, severe dyspnea. BP is 180/100. So BP is very high. Patient is pulmonary edema. Severe dyspnea is there. Which drug provide the fastest symptomatic relief? If the patient present with acute pulmonary edema, the patient is having the congestive heart failure. This is a typical case of acute left ventricle failure. Patient is in pulmonary edema, there is dyspnea, there is high blood pressure. Always and always provide the symptomatic relief first. And to provide the symptomatic relief in these patient, always and always we give the loop diuretics. Loop diuretics are the first choice. You can remember the important drugs for this. LMNOP. L for loop diuretics, M for morphine, N for nitroglycerin, O for oxygen, and P for position of the patient, so that the patient will not feel the chest pain or dyspnea difficulty. So head side up. So loop diuretics, morphine, nitroglycerin, oxygen position. The loop diuretic is the first choice. If chest pain severe, not controlled by loop diuretics, morphine can be used. Nitroglycerin is for ischemia. If there is heart is in ischemia. So what is the best option? Yes, so you can see spironolactone is the drug for chronic heart failure. That is a potassium sparing diuretic. It decreases the remodeling process, can be used in chronic heart failure. Enalapril is also for decreasing the remodeling in chronic heart failure. Digoxin can be used for symptomatic relief, but it is mainly for controlling the rate and to increase the pumping. But furosemide is the drug which decreases the load, it decreases the edema, and it's a drug of choice for pulmonary edema. Very good drug, loop Lasix, furosemide. Next question, simple question, drug causing gingival hyperplasia. Gingival hyperplasia, there are three important drugs. You can remember the three important drugs. NCP, National Conference Party, NCP. So N for nifedipine, amlodipine, calcium channel blocker, dipines. C for cyclosporin, immunosuppressant, and P for phenytoin. These drugs are causing gingival hyperplasia. Always advise soft brushing. So nifedipine, cyclosporin, and phenytoin. So you can see out of these we have one option, and that is amlodipine, nifedipine. Otherwise no. So that is the drug causing gingival hyperplasia. Right? Simple question, but you have to remember some important things in medical science. You have to remember something. So this is the thing you need to remember. Hypertensive emergency in pregnancy. What is the drug of choice? What is the drug of choice for hypertensive emergency in pregnancy? Always remember, for hypertensive emergency in pregnancy, labetalol is the drug of choice. Always remember this. Beta comes in pregnancy, so that is labetalol. That is the drug of choice. If labetalol fail, then we think about the calcium channel blocker, nifedipine. Nifedipine is also good option. Hydralazine, then comes hydralazine. The sequence is very important. First labetalol, then nifedipine, then hydralazine. And last resort is sodium nitroprusside. That is the last option. Losartan to beta contraindicated. Rest of the drug can be used, but out of ACE inhibitors contraindicated. So labetalol is the drug which is the drug of choice, but remember this sequence: labetalol, nifedipine, hydralazine, and sodium nitroprusside. Next question, 40-year-old with stable angina develops erectile dysfunction after medication. Which is the likely drug? 40-year, that is a young patient like us, stable angina, develops erectile dysfunction. So in stable angina, which drug we give so that patient is having some problem? And this is the reason in young patient, when we start this drug, we need to be very careful. So what is the drug? In stable angina, as I told you, decrease the workload. That is the primary. And we use the beta blockers. So either they will ask you directly as which is the best drug, or they will ask you indirectly which drug can cause erectile dysfunction in stable angina patients. So no, ranolazine is not causing erectile dysfunction. So you can see it's a beta blocker which can cause this. So nitroglycerin, no, even they can help because they are vasodilator. They act like sildenafil, so they can cause erection. Amlodipine, it's a vasodilator, even it is not causing erectile dysfunction. Right? Ranolazine is not having a role on hemodynamic profile, not having role in vasodilation, vasoconstriction, no. But it's a beta blocker like propranolol, which can cause vasoconstriction, which can decrease the penile circulation, and which can decrease the libido. Even the sympathetic activity is down, so you will feel decreased libido, you will feel low. And this is the reason in young patients, when we give the beta blocker, sometimes the patient comes because of this sexual dysfunction. Don't forget it. So beta blocker. Non-selective is having more risk. Cardioselective drug is better. Next question, a patient on nitrate develop tolerance. You know that is very common problem with the nitrates. What mechanism is there? What mechanism is there? So as I told you, nitrates are releasing the nitric oxide. They release the nitric oxide. So these are nitric oxide donor, but these are not direct donor. They are donating this nitric oxide via sulfhydryl mechanism. Via sulfhydryl. So if you give this, there will be sulfhydryl depletion with the time, and that can lead to decrease the effect of nitrate. So the mechanism to develop the tolerance is sulfhydryl depletion. Reflex tachycardia is a side effect. Increased metabolism is not the reason. Metabolism will be decreased, not increased. Receptor down regulation is not the reason. There is no receptor for nitrate. So they are nitric oxide donor, and there is a dependent mechanism. Because of this, sulfhydryl depletion leads to decrease nitric oxide release, and that can decrease the effect. This is the reason we advise for. This is the reason we advise for, if tolerance occur, we advise for how to avoid the tolerance. We advise for nitrate free. We advise for nitrate free period, or you can say nitrate holiday. If you give the holiday of nitrate for some time, the tolerance will be reversed. The body needs some time. Nitrate free period. So in the nitrates we don't give in the night time we don't give nitrates. When the night time the body is free of nitrate, in morning you will see nitrates are effective. And this is the reason that nitrates alone not used in chronic angina. We use beta blockers. So we already discussed question, which antihypertensive is contraindicated. By chance it is repeat. Bilateral renal artery stenosis already discussed. It is the enalapril. You can see the previous question, you get the answer. Acute pulmonary edema with dyspnea. Again it is repeat. Acute pulmonary edema with dyspnea, immediate drug. So we already discussed, it is the furosemide. It is the furosemide. So again you can go back and see the question. Okay. Hypertensive patient with migraine prophylaxis benefit. No, bache. In acute pulmonary edema, just now we have discussed. We use the furosemide. And in this, enalapril. Okay, you are telling about enalapril. No problem, sorry. So hypertensive patient with migraine prophylaxis benefit from. Patient is hypertensive as well as patient is having migraine repeated attacks. So we need to give migraine prophylaxis, which is the best drug, which can control the BP as well as control the migraine. One drug having both option, which is the best drug for this purpose. It's a beta blocker. It's a beta blocker, propranolol. Propranolol is the drug which can control the migraine attacks. It is reaching to brain, decrease the irritation of neurons, decrease the blood circulation, and because of this, pulsating headache, migraine will be less. Even it can control the BP. So it is the propranolol. Amlodipine itself causing headache, because amlodipine is a vasodilator. Enalapril having no role in migraine patients. Prazosin, even they can cause the headache. That is the propranolol, which can decrease the migraine prophylaxis. The wonderful drug for these patients is propranolol. Always remember, hypertension with migraine, heart patients with migraine, it is the propranolol. If mood disorder with migraine, then we think about the drugs for mood disorders like valproate. We think about the antidepressants, tricyclic antidepressants, amitriptyline. So that we have discussed in the CNS. Or migraine we have discussed in the autocoids. So you can refer those questions. A patient with non-STEMI. A patient with non-STEMI should not receive. A patient with non-STEMI should not receive aspirin, heparin, streptokinase or clopidogrel. Non-STEMI patient, non-ST segment elevated myocardial infarction. Non-ST segment elevated myocardial infarction in non-STEMI patients should not receive. So in these, what is the treatment? We use the drugs like aspirin for antiplatelet purpose. You can use clopidogrel as well, that is antiplatelet. we use the nitroglycerin or GTN. Nitroglycerin is a GTN. We use the oxygen if hypoxia. We use the morphine if severe pain, but that is not usually required in non-STEMI. And we use the anticoagulants. In anticoagulants, usually we use the nowadays LMW heparin, but we can also use the heparin. Usually heparin is given for IV use like in the PCI patients, but otherwise we can use the subcutaneous enoxaparin. So these are the things we required, and definitely we required the beta blocker. We required the atorvastatin. So these are the drugs we required in non-STEMI patients. So remember, first we need these drugs. So MONAS, or you can say Sonam. This is S for statin. S for statin, oxygen, nitroglycerin, aspirin, morphine. These are the priority. Other than Sonam, we need beta blocker. We need the beta blocker and anticoagulants. We need the beta blockers and anticoagulants. So out of these, you can see aspirin is definitely for antiplatelet purpose. We give the chewable aspirin 325 mg. Heparin can be used as anticoagulant. Clopidogrel can be used as antiplatelet. There is no role of streptokinase in non-STEMI. Streptokinase is a thrombolytic agent, and streptokinase is used for, we will discuss in detail in hematology, streptokinase is used for the STEMI patients. That is not for non-STEMI, because we need to see the risk of bleeding as well. So that is for STEMI. In STEMI, even the PCI is the preferred choice, but you can use the streptokinase, urokinase, alteplase. Nowadays we have the tenecteplase. So that is the drug. Digoxin toxicity with hyperkalemia. What is the best antidote? You know, when the digoxin toxicity occurs, hyperkalemia risk is there. What you will, how to manage? Because usually in digoxin toxicity, if the potassium is low, we can give the potassium. Potassium will decrease the binding of digoxin. Potassium will decrease the digoxin toxicity. But in this case, already there is hyperkalemia. So how you will manage? We need to give the antidote. And what is the best antidote for digoxin? That is DZ-Fab. So the Fab fragment we use, and that is called as DZ bind. So DZ bind is the best antidote, because dialysis is not effective. Dialysis is not effective. DZ bind is the drug we are using in digoxin toxicity, right? I think every bacha knows this. Best drug for isolated systolic hypertension, that is commonly seen in elderly patient. Isolated systolic hypertension, only systolic BP is high, diastolic BP is not high. What is the best drug? And it is very commonly seen in the old patient. The best drug for these patient is always and always, in old patient, consider the thiazide diuretics. In all these patients, give the thiazide drugs. These are the diuretics, and they will decrease the extra volume. They are also having some vasodilator property. They are the wonderful drug for isolated systolic hypertension. Right? So remember this thing. In isolated systolic hypertension, the best drug will be diuretics. One important question: mechanism of ranolazine in angina. Mechanism of ranolazine in the angina. So what is the mechanism of ranolazine in the angina? Ranolazine, important drug in angina patient. Mainly it is the late sodium current inhibitor. When you inhibit this late sodium current, it decreases the calcium entry in the myocardium, which decrease the myocardial contractility. And you can say decrease the workload. But it is also partial fatty acid oxidase inhibitor, PFOX inhibitor, which also decrease the oxygen demand, because heart will not use the fatty acid, heart will use the glucose, and for glucose less oxygen is required for glucose oxidation. Less oxygen is required. So ranolazine is the drug. By now you can remember, it is sodium current inhibitor. So it is not nitric oxide donor, it is not a beta blockade, it is not a calcium channel blockade, it is a late sodium current inhibitor. Wonderful drug. But with this, we have seen the risk of QT prolongation. We have this risk of QT prolongation seen with the ranolazine. In PFOX inhibitor, we have one important drug, and that is trimetazidine. That is trimetazidine. Trimetazidine. Yes. Very good, bache. So let's discuss the clinical question. A 64-year-old man with long-standing hypertension, present with progressive dyspnea, echo showing EF 30% only, creatinine is mildly elevated, started on enalapril. 3 days later, serum creatinine level is significantly raised. What is the most likely mechanism? So usually if the patient is old, hypertension, EF is less, definitely ACE inhibitors, ARBs can be used. But in this case, we have seen the serum creatinine level rise significantly. What is the likely mechanism? So as I told you, when we use the ACE enzyme inhibitor, it is one of the ACE enzyme inhibitor. When we use the ACE enzyme inhibitor or ARBs, they dilate the efferent arterial constriction. So they dilate these vessels. Because of this, what happens? Because of this, decrease creatinine clearance, because the pressure will decrease. The pressure will decrease, and that decrease the creatinine clearance. So decrease the creatinine clearance, which leads to increased serum creatinine level. This is the reason. I already told you about this. So that is the ACE enzyme inhibitor. Because they relax these vessels, GFR decrease, filtration decrease, so that leads to decrease creatinine clearance. Next question is 58-year-old post-anterior MI patient is hemodynamically stable. Which drug prevent remodeling of ventricle and improve the survival? If the patient is hemodynamically stable, acute there is no problem, but now we need to decrease the remodeling process and we need to improve the survival. Very good, Uttam. Good mnemonic. So, ventricular remodeling and improving the survival. So, in these patients, basically it is a compensated heart failure. We need to inhibit these compensatory mechanism. And this is RAS pathway inhibitors. So when you inhibit the RAS pathway, compensatory mechanisms will be decreased. You decrease the remodeling, you decrease the survival. In RAS pathway inhibitors, we have the beta blockers, we have the ACE enzyme inhibitors, we have the ARBs, we have the ARNI nowadays, angiotensin receptor blocker and neprilysin inhibitor, and we have the potassium sparing diuretics. So these are the drugs we use. So nifedipine is a calcium channel blocker. Digoxin is not for this purpose. Verapamil is a calcium channel blocker. This is the ACE inhibitor. So beta blocker, ACE inhibitors, ARBs, angiotensin receptor and neprilysin inhibitor, and potassium sparing diuretics. So these are the drugs which we are using. There is no other important drug for this purpose, but we have nowadays SGLT2 inhibitors also decrease some remodeling improve the mortality, but not via this mechanism, gliflozins, and even hydralazine is having some role in the mortality. Rest of the drugs are not for mortality. These drugs are primarily for this mortality. Already discussed question, means I gave you the concept. 70-year-old patient with reduced ejection fraction heart failure develops atrial fibrillation with rapid ventricle rate. The patient of reduced ejection fraction heart failure now having atrial fibrillation. So arrhythmia, BP is low. What is the safest drug for rate control in these cases? I told you, in these type of cases, when the heart is not working properly, when the fibrillation is there, never use beta blocker, never use calcium channel blocker, because they can suppress the heart, they can control the rate, but they can decrease the ejection fraction. in these cases the best is digoxin. It's a positive inotrope with negative chronotrope. It's a positive inotrope with negative chronotrope, we already discussed, so that is the digoxin. And the last question is, a patient on digoxin developed nausea, yellow vision, ventricular arrhythmia. So this is digoxin toxicity. This is digoxin toxicity. Digoxin is a narrow therapeutic index. Toxicity is very common. Potassium level is, you can see, potassium is 6.2. The patient is already having hyperkalemia. So what is the reason? What is the reason for this hyperkalemia? So if you see the digoxin mechanism, digoxin is a sodium potassium ATPase inhibitor. Sodium potassium ATPase inhibitor. So when you inhibit this sodium potassium ATPase, there is one calcium sodium calcium exchanger. So you can see when you give the digoxin, digoxin bind over this site. Digoxin bind over this site. You block this, potassium not enter, sodium not coming out. So that leads to sodium calcium exchanger. Calcium coming in, sodium is definitely going out. So this is Sarka channel. So there will be increased calcium from the Sarka, and that leads to contractility. So you can see when you give the digoxin, the sodium potassium ATPase inhibit, that leads to increased potassium concentration outside the cell. So this is sodium potassium ATPase. This is the reason this drug is causing hyperkalemia and risk of toxicity. So whenever toxicity is there, we give the KCL, but already hyperkalemia, there is no role of KCL, we give the DG bind. So that's all about this class. This is my Instagram handle. If you have any question, any doubt, you can ask me on Insta. Dr_Dinesh Yadav. So thank you guys. Again I would say happy Holi. खुश रहो, मस्त रहो, होली को एंजॉय करो, पढ़ते रहो, मस्ती भी करते रहो. दोनों चीज़ लाइफ में इंपॉर्टेंट है. लाइफ भी दोबारा नहीं मिलेगी, ये टाइम भी दोबारा नहीं आएगा. हैव फुल एंजॉयमेंट, हैव फुल ऑफ लाइफ, बट साइमल्टेनियसली कीप स्टडिंग. थोड़ा थोड़ा पढ़ते रहो. कंसिस्टेंसी इज वेरी इंपॉर्टेंट. एवरी मंथ वी आर हैविंग द सेशन फॉर वन टॉपिक, right? Next time we will discuss hematology. So every month we are having one session. उस मंथ उस टॉपिक को पढ़ो, इसके एमसीक्यूज देखो, रिवाइज करो. थोड़ा थोड़ा पढ़ते रहेंगे तो कभी बर्डन नहीं आएगा, कभी स्ट्रेस नहीं आएगा, और लाइफ भी मस्त चलती रहेगी. हमने लाइफ में यही किया है, मस्ती, थोड़ा थोड़ा स्टडी, आज ठीक ठाक जिंदगी बीत रही है, स्ट्रेस नहीं है. तो इसलिए स्ट्रेस नहीं लेना है, तो थोड़ा थोड़ा करके चलता रहो. एक साथ पढ़ोगे बर्डन आ जाएगा लास्ट में बहुत ज़्यादा. इसलिए कीप स्टडिंग, कीप वर्किंग, बट don't miss the enjoyment in the life. So thank you, bye bye, take